appreciate your time and coming in to go through this presentation today. When I spoke to Gina earlier, we were going to focus obviously quite a bit on social determinants of health analysis, but I also wanted to make sure we talk today about how we've been using our SDoH analysis and incorporating into our program to make sure we can kind of get the outcomes that we're looking towards. Our philosophy around population health at Lifebridge is to make sure that we are driving towards holistic care, to make sure that all of our programming is really data-driven, and to ensure that we have a very integrated approach, not only within our own care continuum at Lifebridge, but also within our community, to make sure we can kind of get the population health outcomes that we're looking towards. So our motivation is very similar to everyone's motivation sitting here today. We're all in different frameworks right now when it comes to population health payment models. But regardless of where we might sit, I think it's very clear that value is the way that we are all shifting from both a federal, from a state, and from our commercial payment models. Are you guys hearing some resonance happening? Let me switch over. Is that better? Okay. And no matter where we stand in this shift, I think it's very clear that there is greater need to move towards value over volume, and there's an increasing push also to two-sided risk. So I did want to give you a little context in how Maryland does have a unique payment model, and important for us to know as we talk about how we've incorporated social determinants of health in both from a data perspective as well as our programming. So in 2014, we entered as a state in the all-payer model with CMS, and essentially what that means is that we've been under a global budget revenue system, very much incentivized over value over volume. So essentially what happens is we're a capitated model, so we get a certain number of dollars for our revenue that is set as part of our fiscal budget as per year, and we are very much incentivized not to go over that, so we think about our preventable admissions as well as our readmissions. Additionally, as part of this model, in addition to the GBR, we also have an all-payer, all-cause readmission model, so we are at risk for about 2% of our revenue if we don't meet our set expectations, and we have an incentive of about 1% under that model. In 2019, we moved from the all-payer model, which was very successful from a CMS perspective in terms of cost savings, to a total cost of care model. And this is essentially a population health framework. So for anyone who was here yesterday with the CMS speaker, we are considered a Category 4 payment model under CMS. We truly are paid based on our population, and it was meant to incentivize thinking about how to transform care delivery, not just within the hospital setting, which was a lot of the work that happened beginning in 2014, but across the entire care continuum. We are also being held accountable for certain population health metrics at the state level, which will also cascade down to the health systems. For example, we are thinking about what type of metrics around diabetes population health management as a state. A little bit about us as Lifebridge. We have 5 hospitals throughout our system, almost 3,000 physicians, and 2 of our hospitals would be considered safety net hospitals by the definition of the proportion of patients that are considered fully dual eligible. We do have a fully integrated care continuum. We do have skilled nursing facilities. We have contracts with Pulse, and we also have a command center. We have urgent care center practices as well as our ambulatory practices. So there is a benefit in being a vertically integrated network in that way. I don't want to make an assumption, but I presume that many folks here, as we think about social determinants of health, as we think about our community health needs assessment, we are trying to figure out ways of integrating that into our analysis. One thing that has been extremely helpful for us is to think about our area deprivation index. As many of you know here, ADI is a way of incorporating various metrics such as income, education, housing, et cetera, down to a geographic region. and the higher the ADI, and this has been associated and linked with health outcomes. So the higher the ADI, the worse health outcomes can be in a geographic region, and on this graph, the higher ADIs are represented by the red, and the lower ADIs are represented by the blue. So as you can see here, 3 out of our, or actually 4 now, out of our 5 hospitals are within this particular region, which has very high levels of ADI. And this is another one of our hospitals that is located in a very rural area, very specific spots with high ADI levels. And why we find this particularly helpful is all of us are aware of the impact of social determinants of health on our health outcomes as we think about the kind of programming that we have to put in place to reduce admissions and readmissions. But it can sometimes be very challenging to articulate that when we think about our senior leadership to the board as well as even to our clinical teams. This has been a wonderful way to start to paint that narrative and help folks understand how and why we have to start thinking about this as an integral approach to managing our populations. What we have found is that the ADI approach, while it's helpful from a high level, it's not granular enough for some of the programming needs that we have, but it's a very good first step, and I'll talk to you about other ways that we're trying to approach this in a much more granular fashion. So for the rest of the talk, I am going to go into a little bit more detail about this kind of stepwise approach when we think about social determinants of health. I would love to stand up here and tell you that we followed this wonderfully organized pathway. That is not at all how we did it. We fell flat on our face about 1,000 times. We did about 100 different pilots, and we had to learn and just pick up as we went along. But about 18 months ago, our teams kind of sat back and said, you know what? We kind of find that we are following a particular framework. We're doing this in a fashion that seems to feel right for us. So why don't we sit back and rather than constantly doing, which is what most of us do, try to see if we can put this down on a piece of paper and put this as a framework, because it will help us, but it's also something that we can use as a learning experience for others, because we're in a very much a learning environment in the state of Maryland, and so we're constantly talking about this with each other. So when we did this, we realized that there is actually a stepwise approach to, and we would have loved if this was something that someone had given to us. So we're happy to share, and please take any tidbits that you find are helpful. One of the key things that we have been doing is very much using a data-driven approach. And what we recognize is we started thinking about social determinants of health very, very early on, back in 2013 and 2014, as we reviewed every single readmission to try to figure out what tactics we were putting in place. What we realized is we just didn't call them social determinants of health at the time. So the way that we had constructed our framework for readmission review is that we had a care manager, member of our care management team, review every single readmission, and they had a very defined set of questions and standardized questions that they were using, as well as a clinician who looked at it from a clinical aspect and clinical care gaps perspective. And then we collated all of their responses. We would do a weekly review of all the readmissions as a group to kind of come up and say, what are the drivers that we're finding? And what we were finding is that our physicians and our care managers were finding a bunch of reasons for these readmissions that didn't really fit into any particular question that we were asking at the time, but it was around things like housing issues. Well, of course, that patient is homeless. Why did we expect them to take the antibiotic that we gave them for 6 weeks? Or, you know, this person wasn't able to get the transportation to come to that follow-up visit that we arranged. So that was the reason that they came back into the hospital. And over time, we were actually able to figure out, and then we started to use a framework around the domains of SDoH to start bucketing these various etiologies. And from that, we found after about 6 months of doing this, about 80% of our readmissions were caused by social determinants of health and not by clinical care gaps. In fact, the clinical care gaps were really driven by SDoH. So the way that we have started to construct all of our evaluations has been incorporating SDoH as part of our analysis. So to give you an idea, these are the number of different drivers that we take a look at. And depending on what we're looking at from a clinical perspective, we will put in standards of care. For example, American College of Cardiology as it relates to heart failure. We will use nephrology societies when we talk about end-stage renal disease. But we make sure we always incorporate what you see here as drivers. The other thing that we found that was very, very helpful is that we started looking at our outcomes not in individual silos, but where did these drivers start to converge? What can happen is when we were starting to look at length of stay, when we were looking at denials, and for anyone here who is in case management or on the acute care side, knows that length of stay and denials tend to go hand in hand. Well, as that same kind of convergence, we realized as we started putting together many of the drivers that were leading to negative outcomes in these categories all were very much the same. So the work that we are now doing with our clinically integrated network, which is who sees a lot of this transparent data and makes decisions from a governance perspective about how do we address these things as a health system, we started making sure there was a great deal of transparency to show how these drivers are all starting to converge. So if you are able to address some of these drivers, by definition, you will impact multiple outcomes at once. And why that's very important is all of us have limited resources, whether it's our time, our workflow, dollars, and what we want to be able to do is put in tactics that are likely going to impact a number of outcomes all at once. One of the other key things that we had to do very, very early on is redefine what unavoidable utilization was. In the beginning, remember I was telling you we had our care managers and our physicians looking at every single readmission. One of the questions we asked each of them was to categorize it as avoidable versus unavoidable. 75% of our initial readmissions were categorized by care management and our physicians alike, it didn't matter, as unavoidable. And when we sat back and looked and said, really, 75%? That seems like a lot. And in the conversation, what happened was we had no framework to address some of the things that they saw were issues. How do you address social determinants of health? We hadn't done that in any holistic, integrated way, and really it didn't feel like the responsibility of either the physician or the care management team or the health system, quite frankly, to do it. So what we often heard is, well, that is a compliance issue from the patient, or it's a behavioral issue of the patient. So we really had to shift that framework from a cultural mindset to say, actually, that is something we can address. A lot of what we're seeing is the lack of our own ability to coordinate care effectively. It's our ability to really make sure, are we reaching out into the community and making sure our patients can get access to some of the resources that they need so that they don't have to come back into the hospital. Once we did that, we found 90% of our readmissions were avoidable. So it was a very, very big shift. And then why that's extremely important is then it allows you to make sure we can get accountability in terms of the tactics that we need to be putting in place. The other thing that we had to look and think about is if we are going to have all of this data around clinical gaps in care and social determinants of health, it became mind-blowing to think, how are we going to put structures into place to address them? So one of the things that we did was to take a moment and really try to inventory all of those things that we actually had in place, whether those were things that we had built ourselves within Lifebridge or partnerships or different programs. And what we realized is we had not done a very good job of connecting people to each other within our own health system, or connecting folks to the kind of resources that existed through our health agencies in the region or other community partners. Sure, people were doing it in pockets, don't get me wrong. We had wonderful care managers who've been doing it for 20 years and knew everybody in the region and when to call them and what time, but it wasn't done in any systematic way. So we did it in a systematic way. First, we took a look at all of our value-based contracts. We have over about 100,000 covered lives, and we risk stratified them, knowing that we're not going to do the same level of resources in someone who is considered very, very high risk versus someone who's in low risk. It doesn't make sense in terms of resource utilization, and that's not what they need based on the analysis. And then what we did was we spent about 2 months really going through, boots on the ground, going through every service line, going through, sitting down and having communications with our care management teams, and just creating an inventory to make sure that we knew what connections existed and to aggregate them in a way that made sense. What will we utilize and what partnerships do we want to make sure we have, and what gaps do we have when it comes to managing our true high risk, our moderate to rising risk versus our low risk? And what we found is we had a lot more than we realized, and our gaps, while they existed, were not as large as what we thought at the beginning. One of the things that we have been doing all along is, I think probably everyone in this room knows, that care management is a fundamental pillar of how to address or how to think about population health management in every facet, especially when it comes to social determinants of health. We took a very hard, good look at ourselves a few years ago to say, did we have the care management structure across our health system, both from an inpatient and from an ambulatory side, to really manage the kind of complexities that we had from both a clinical care progression standpoint as well as from a social determinant standpoint? Remember all of those outcomes that we had to think about in population health. And as a physician, I previously came from a very large multi-specialty practice as a cardiologist. I was very used to care management, but I have to tell you, in my role as population health and overseeing care management, I've had a eye-opening experience. I've had the privilege of overseeing care management and realizing I didn't really know what care management truly did. And what I recognize is many people don't really recognize what care management can do. And sometimes even care management doesn't even recognize how much care management can do. So we spent a great deal of time defining roles, responsibilities, really digging in deep about what are our needs, how should the clinical expertise of a nurse be utilized to maximal effectiveness, how should the clinical expertise of a social worker be utilized, a community health worker versus a navigator. There was a lot of lack of role clarification and delineation that needed to be cleaned up. And that's an always ongoing process based on how we structure our education and development. Then the other thing that we realized is, as much as we felt that our teams were integrated, there was a lot of opportunity. What our teams thought were integration was that they had good relationships with some of their physicians or with some of their other partners. That was very different from maximizing the kind of integration that you needed by workflows, by process enhancement, by making sure there was open communication, that there was a system that allowed our communication to go back and forth when you'd had completely different EHRs, that you actually talked through patient stories together as well as outcomes. That's a very different look for integration, and we've had ongoing work around that, but that's the level of work we needed for care management. And the other thing I had to do was a complete switch, but really, how do we think about outcomes with care management? I'm used to dealing with physicians. We love data, more and more data. We want to hear how a program is doing, so I was used to that kind of conversation. What I realized with our care management teams is we lead with patient stories. The patient stories is actually how that first gets the resonance, and then we talk about the data and the metrics, because otherwise it can feel like death by metrics. One of the other things that we have been doing is really talking about what shared accountability means to address social determinants of health. So remember when I was talking about care management, as I was going around to all the different clinical service lines and talking to our chiefs of service and talking to our ambulatory practices, everybody in those practices really knew about social determinants of health. They didn't know what to call it, but they knew that, listen, I have a challenging patient for X, Y, and Z, and it's not about the clinical care I'm providing, it's about all the other things when you think about holistic care. And I would say, great, how do you think we should address it? And they say, great, can you just hire me a care manager? Because that'll take care of everything. So, well, we can't hire a care manager for every single practice. That's generally not going to work, and it's going to bankrupt us as a health system. But they do have some defined roles and responsibilities. How do we do this in partnership with each other? Because there are some things that we need our physician partners to do and practices to do that are different from the unique skill sets of our care managers. So one of the big things that we started having folks do in our practices and our service lines is actually use an abbreviated social determinant of health assessment. That gave a very defined role for everyone within the health system, because what we were finding is that we as clinicians in particular were not always good at picking up SDoH needs until it became very, very obvious. So obviously the homeless patient who is in your place and you're trying to figure out how to, set up surgery, very much a need. But what about things about food issues, in your geriatric population that might be contributing to the fact that they may not be absorbing medications or may have issues really sustaining the kind of level of medication that you need? What about financial insecurity that may make it hard for that patient to take the 2 or 3 drugs that you're recommending as a clinician, and they feel embarrassed to kind of tell you. So what we did was we used the CMS AHRQ tool that is standardized across our health system. Our care managers do a full assessment once they're referred, but we have essentially asked all of our clinicians and all of our service lines to do a 5-point questionnaire that allows then for appropriate referrals to happen. And then we use our care managers, obviously pull in lists from our high risk and our rising risk from all of our payers to make sure, but this allows for a conversation around, we are all in this together and we need your help. The other thing that we did and highly recommend is to think about how you're going to maximally utilize your community resources. This is not something a health system can do by themselves. We are talking about substantial infrastructure needs within a community, certainly within a region, and all the way up into the state, and you need partners. So we have spent a great deal of time creating and working, establishing partnerships with a number of different health agencies and different folks who really are very well versed in this and much better oftentimes at this than we are. They really can think about grant funding and other ways of doing this. They often have deep reaches into the community and work with a lot of the civic leaders to make sure that the practices and workflows can be implemented in a meaningful way. Sometimes the health systems can be seen, as gorillas in that area, and so this is one of those that when you partner with the right folks, it can be done with finesse and in a way that's going to get you the maximal outcomes that you need. So when we think about social determinants of health in terms of our strategy at Lifebridge, it's always, do you buy, build, or do you partner? And partner is always, always the thing that we go to first before we're thinking about buying or building. So in doing that, we have actually increased our partnerships. We now have over 400, and we have over about 100 Lifebridge-specific programs that we either have built on our own or we provide a substantial amount of financial dollars towards. And all of these are addressing various domains around social determinants of health. But for the majority, as you can see, we really rely on our partners to do it. It's the connections to make sure we're then putting our patients into those programs. The other thing to think about is, what about those non-traditional resources to address some of our population health needs? So to give you an idea, chronic kidney disease is the #1 patient population for Lifebridge and for many areas in the nation when it comes to cost and utilization. So when we did a deep dive on this patient group, as no surprise, it came out that our dialysis patients were a primary driver of that cost. And when we took a look at that, well, one of the biggest needs that we saw is within multiple regions, we had a number of our patients who were not getting their fistulas in a timely fashion. There was a significant lack of a number of standards of care around dialysis that was not being met. So we sat down with our dialysis partners and we reviewed this data. And generally, there was a lot of finger pointing on both sides going on, to be very honest with you. They didn't feel like we were doing things as a health system appropriately. We didn't feel like they were doing things. And so the tenor of the conversation changed when we said, look, this is our population. We have to manage these costs and utilization together. We, in the state of Maryland, have a very high need in order to do so. As a health system, we probably have a little bit of an even greater need than the dialysis folks, but they still benefit from this because they have a lot of frustration. They're also moving towards models, as you know, from a CMS to really think about bundle payment and the right kinds of care that need to happen. So we created a model with clinicians on their side, with clinicians on our side, as well as care management resources. And what we have found now is by reviewing our cases of our high cost, high utilization patients, we have actually reduced utilization by over 60%. And now we have funded a end-stage renal disease navigator through that work, because we have an ROI through that, to manage about 250 to 300 patients. And what we're really looking towards is now not just focus on the tip-top of high utilization, but we have found a number of things that are happening that we are going to be placing as tactics and workflow that will happen prior to patients even coming into the ED or into the hospital, but right in the dialysis centers themselves to try to prevent that high cost and utilization. Again, we never would have thought of that group as a partner. We just really thought of them as an adversary for some time. The other group are skilled nursing facilities. Another challenge, when we took a look at our readmissions in about 2017, we saw a rise in our skilled nursing facility readmissions by 30%, and no one could really help us understand why. So we had a lot of discussions, and again, a lot of case reviews, a lot of finger pointing initially, but it moved away to a much more collaborative model and some collaborations between our care managers as well as their care managers. There was a complete lack of communication. We use a system of different kind of care alerts and communication tools now to put some processes in place when a patient is in the hospital in terms of community resources that we hand off to the skilled nursing facilities, and they on their side, if they have any concerns that a patient is a potential readmission back into the hospital, they have a communication method to allow us to know, and we have medical to medical director contact now. So a medical director of population on our side works with all the medical directors there. Every single readmission is sent to them for a clinical review to see what could have been done to help prevent that readmission. Again, that kind of partnership didn't exist before, and in this case, we didn't have any additional resources that we had to apply in there. What we did was focus the folks that we had on the right kind of problem solving. Now, one area that we have spent dollars on is Uber Health. When we took a look at one of the biggest social determinants in the beginning that was driving unnecessary utilization, it was around transportation, and that was in multiple geographies. So we contracted with Uber Health to essentially manage this for us, and so our care managers and different groups are given the ability to provide transportation vouchers through Uber Health to make sure that our patients can get to the key appointments, especially during those transitions of change. One of the other key things that we have done, and I know everyone is doing, is really trying to think about leveraging health information and your care delivery technology. So this is a challenge. I cannot tell you that this is done extremely well. We all have challenges around it. But the way that we have been doing it is recognizing, we get claims from all of our payers. We have a number of information from a Cerner-based platform for population health that we use. So we integrate all of that information. We work also closely with CRISP, which is our health information exchange in the state of Maryland. And utilizing all of this, what we are trying to do is to find all of those drivers, as I mentioned before, but then to make sure that we get actionable information to the hands of our practices at the moment of care in the ambulatory side to the best that we can, as well as to our care management teams. And now also with a lot of the work that we're doing is with any of our partnerships in the community. So we do have care alert systems. We do have ways that we can take our high-risk patients and put them on co-managed lists through CRISP so that both teams can get alerts. And that has been an extremely helpful way for us to try to manage this. The one area that we're now looking towards and really trying to leverage is around the variety of care delivery technologies that all of us are using. So we have a number of telehealth ways that we are partnering. We have a number of wearable devices. But what we recognize is we're not really leveraging a lot of the information that we get from those patient care delivery models, and we're working with contracts as well as with those vendors and technology to say, how do we start incorporating that data into something meaningful? What we long recognized is there will not be just one solution to support population health. So we recognized early on is that we need to create really an integrated model of various sources to be able to get the kind of data analytics that we need, the information that we need to think about social determinants of health as well as clinical gaps in care. So I mentioned to you earlier on, even though we have the ADI by the various regions, that's really not discrete enough for us to think about what are those true drivers when it comes to social determinants that we need to be addressing for these populations we have to manage. Often we think about populations based on their clinical DRGs. So we are working with a group called Socially Determined, and what we are saying is for these high cost, high utilization populations that we're going to be overseeing and making sure that we are improving, heart failure, diabetes, end-stage renal disease, we want to know down to a discrete level, down to those neighborhoods, because care is local, what are the actual primary social determinants that are leading to the negative health outcomes. That allows us to be much, much more focused then with our care management teams and with our practices who are in those geographic areas to say, think about your heart failure patients in this zip code where the primary need is around transportation, and that's why you're not getting the heart failure outcome that you want, even though you're providing the medicines. So let's really make sure that we address it by doing this particular tactic. You may not need that in another zip code where it's more around financial insecurity, and we have to make sure our care management teams are resourced and our practices are resources to address that. NowPow is a tool, and I'll just focus on these two, is a tool that we are going to be implementing in the spring. And what that tool does is, what we found is, I mentioned to you, we have about 500 different resources that we can utilize to address social determinants of health. Well, right now, all of that exists on a very large spreadsheet. And it's a very static piece of paper. And who can remember 500 resources, especially when care is so local, and our patients are not going to use a resources that is 2 zip codes away. So NowPow is a way for us to take and actually pull in social determinant of health, whether it's done through the practice, through that 5 questionnaire, whether it's done through our care management team, or if it's pulling in information through our EMR. And then it's allowing us to say, based upon this and based by your patient's zip code, it looks like they would benefit from the 5 to 10 resources that exist over here. So that's a very helpful way for us to maximize the resources that we have and we know we're not maximizing yet. But additionally, the other thing that we've often noticed is sometimes, even though we have a number of partnerships, it's very hard for us to tell whether those partnerships are effective at managing our patient populations. So for example, I could send 50 referrals to a particular community-based organization, but the penetration rate of that might be only 2 patients. And I want to know why. And we often can't have that conversation. Is it something that we need to be doing on our side? Is it something perhaps that they need to be doing on their side? What NowPow will allow is also a very strong analytics tool, which all of those referrals then every month will be able to see for these social determinants. These are the referrals that were offered. These were the penetration rates that were actually picked up by those programs. And then I can actually link it to the outcomes of our population to work with those CBOs to say, you know what, I really need you to scale because you're doing great, but you can only take 50% of our patients. Or we sent you 25 and you're only taking 2. Are you the right partner that we need to be partnering with? I think everyone knows it's extremely important if you're thinking, especially around social determinants of health, and certainly managing population, you must think about your outcomes rigorously. We have been following our readmissions as well as our avoidable admissions, and the state, because of our population health framework, provides us a lot of this information, but we do break it down even further to certain other populations to see if our outcomes are working. So as you can see there on the left, our readmissions really have dropped by double digits in multiple different payer groups, including challenging ones like Medicaid, as well as clinical challenges such as behavioral health, and we have got numbers in the 25 to 30% range, which is quite significant. On the right here is a concept of potentially avoidable utilization, which is really thinking about PQIs or certain diagnoses that has been deemed really not appropriate for hospital-based utilization. And again, through this approach, we have seen significant improvement in our avoidable hospital-based utilization as well. Something that's very, very important for everyone to consider, and this is when I mentioned we've fallen flat on our faces about 1,000 times. This is something we did initially, and thankfully we're able to pick up and have put into place a structure to help prevent that, and that is the idea of the regression to the mean. Folks have probably seen the New York Times article about the Camden Coalition and some concerns that that kind of holistic approach didn't provide the kind of outcomes that that group had wanted. And one of the things that was brought up by the teams who looked at the data is this idea of the regression to the mean, which is, especially when you look at a high utilization population, almost anything you do can lead to what looks like an impact simply due to the progression of that clinical care, due to a number of different factors, and that's what we saw initially when we did some of our readmission program. We said, my goodness, look at this. Our programs are causing an 80% decrease in utilization, everyone gold star. And then what we realized is, well, when we put a control group, that number did go down substantially for some of our programming. So what we do now is that we make sure that for every single one of our population health programs, we always have a control group that we utilize. And again, we use something called a CRISP panel, which is our HIE. That way it's kind of out of our hands as well. It's being done sort of by a third party, and so doesn't hopefully put any kind of bias for us. So we put our patient to whatever cohort is getting the active intervention as well as a control to follow so that we can make sure that we aren't burned by this regression to the mean. It's something important for everyone to consider as you're doing this. And finally, the other thing is we know that the challenge that exists for funding a number of these things comes down to how are you going to track return on investment? There are a number of different tools. Health Catalyst in 2016 gave a different way of thinking about the cost-benefit analysis for a number of these kind of programmings that exist for population health and when you think about social determinants of health. This is incredibly important, especially when you want to go to your CFO, when you're talking to your board and your different senior leaders, to really think about the outcomes. One of the benefits in the state of Maryland is because of our population health payment model, every single readmission clearly has a dollar value. Every potential avoidable utilization admission has a dollar value, which is what we use to calculate our ROI because it's part of our volume proposition. What I would say for those of you who are not in a Category 4 population framework, what you do is take a look at all your value-based contracts, because this is something else that we've done. And in all your volume-based contracts, those drivers addressing social determinants of health, you will see that a lot of your volume-based contracts are based on a lot of the cost will come from inpatient utilization. So if you can look at your drivers of social determinants of health and say, if I can decrease some of this inpatient utilization in some of my populations of my value-based contracts, that allows me to actually meet the requirement, even beyond the quality requirements, to actually meet my ACO metrics or another kind of value-based payment. And all of that can be incorporated when you're thinking about your ROI. The other thing to think about funding, and this is really where your community partnerships become very, very important, is everyone is kind of going after the same degrees of funding, but as we have been very good about thinking about our partners, we have started working very closely with partners that we know probably have greater access to larger degrees of funding. Within the state of Maryland, there's only a limited amount of pots in different areas, but what we're really thinking about are different national sources, and especially because we're in the kind of payment model that we are in, the broader we think about our partners, the more likely they are to have resources to the funding that we may not normally think about as a health system. The other thing is donors are increasingly, obviously we've all probably used our development funds and different areas, but donors are increasingly thinking about ROI as well. So we've been very good about utilizing our ROI to say not only are we getting these kind of patient stories and health outcomes, but look at the kind of return, and now we really need your support for scaling. So we take our pilots and then we're really asking our donors, we've done this for 250 patients, allow us to think about how to do this for 2,500 patients. So overall, these I recognize, and I just want to salute everybody who does this kind of work on a day-to-day basis. Improving outcomes for populations truly is complex work. There is no one set framework that is going to be a plug and play for anyone, but what we found was these concepts that you see listed here really has led us, because we've been following them now consistently, to have year-over-year reductions for not just readmissions, but also avoidable utilization, denials, length of stay, a number of other metrics that really point to the ability to provide health for our populations. So I appreciate your time. Thank you.
Congratulations. Your success is clearly flowing from a very organized approach.
Thank you. Team effort, by the way.
Always true. I'm curious to hear a little more about, you touched on this this magic black box of care management and people outside of care coordination and care management not understanding what that is. Okay, so I could talk about care coordination for hours, but after about 3 minutes, you see people's eyes glaze over. So what's your elevator speech for when important stakeholders outside of coordination ask, what does care management do?
So we actually created a nice little PowerPoint to do exactly that with our teams, but I have to tell you, one of the most important questions because you're right, they will glaze over if it's just, we first ask them, what do you think care management should do? And I will tell you, when we met with our team, with all of our various service lines, I can tell you the number one answer is more around a lot of clerical support and a lot of the kind of what I would say is what I would consider as practice-based office care coordination that their own teams or their service lines should be doing, but they kind of thought or assumed that the social worker in particular was going to do. They had no idea even what an RN really did it all. They didn't even know RNs were part of the care management team for many who were involved. They're just social workers. So so that conversation has been the most helpful. And then what we were able to do is say, you know what, we don't do this. This is what we do, as you can see by our roles and responsibilities. But let's talk to you about how we might readdress some of those things that you might be asking our teams to do and feeling like you're not getting what you need, into what could you do even in your own framework of your practice or in your clinical service line to get this done. That has actually been the most helpful. It was eye-opening, I have to tell you. You're welcome.
Questions? Oh, one more, and then we'll move into the next section.
Thank you so much. I was really interested in your slide, step 10, where you're looking at leveraging the multiple funding sources. Can you walk me through the graph and explain what that tells you and how that informed what y'all were going to do going forward?
Sure. So, this is from the Health Catalyst article in 2016. It's just a different framework that, so we have a very specific way that we calculate ROI for our population health programs is based on our FTEs. And then, as I mentioned, the values that are given for every readmission or what we see from value-based care. But the idea here is every one of your programs is going to have a cost to it, right? So when you do telemonitoring, great, but there's a big cost to it. And the cost that you want to think about is not just the cost of the equipment, but obviously the cost of the resources of your teams. Now, just because you've had those folks like care managers, et cetera, they're going to have to take some time now to monitor the telemonitors and to do something about that might have taken them away from doing something else. So it's very important for us when we do it is to assign every single possibility of cost. And then from a benefit standpoint, what we said is we want to make sure there's a dollar value for the benefit. So for us, we did look at what is the cost. So for example, for some of our hospitals, every readmission is $14,500. So a potentially avoidable utilization might be $7,500. An ED visit might be is going to be less, right? The other thing that we also did from a benefit standpoint is, remember, a number of things by preventing the patient from going to the ED, we got a primary care visit out of it. So we saw that as a positive benefit, right, that we incorporated also into the benefit side of things, because that patient wouldn't have gone for that. So by doing that, we were really able to create a cost-benefit kind of analysis. That helped us figure out when we wanted to fund things, what is the right resource to fund. Many of our donors wanted to see, listen, we've done a great job with telehealth, but we can only do it for 250 patients. We've done great, and we put some patient stories and put it in there, but then said, we really want to do it for 2,000, and this is what it's going to cost to get that same degree of benefit. I hope that answered the question. Okay.
Thank you, Dr. Manning.
All right,
That was
thank you,
excellent.
everyone.
Thank you.